Dear colleagues, it's my pleasure to talk about the management of hyperpigmentation of the face. Here are my disclosure. So, as you know, pigmentary disorders are very frequent and they frequently alter the quality of life of affected individuals. And thus, there are a strong therapeutic demand. So, we're going to see how to manage the best, the most frequent hyperpigmentations. So, as you know, most of the pigmentation of the skin is melanin, but we have also other pigments such as hemoglobin or carotenoids that can give dyschromia. But also, dyschromia can be due to abnormal accumulation of an endogenous pigment such as bilirubin, or accumulation of exogenous pigments such as cider or other type of pigments. So, we're going to talk today mostly about melanin hyperpigmentation. So first, what we need to do is to use and adapt photoprotection. Most people, when they choose, when they are choosing a photoprotector sunscreen, they are just will look at the SPF. But as you know, SPF will reflect mostly the protection against UVB. And we know now that when it comes to the pigmentation, UVA, and especially long wave UVA called UV1, play a very important role. You can see here, for example, two sunscreen with the same protection against UVB, so 50 SPF 50, and here a protection factor against UVA of 13. You can see how after exposure to sun you have this hyperpigmentation. Here, the same protection against UVB, but a better protection against UVA, and you can see how you protect much better your skin. And it's the same for acute or daily exposure. So clearly, we have to choose a sunscreen with a very good protection against long wave UVA. What about other wavelengths, especially visible light? It's now well demonstrated that visible light is able to induce, at least in skin type 4 to 6 patients, a very intense and prolonged hyperpigmentation, as you can see here. And interestingly, this hyperpigmentation was not observed in light skinned individuals. And this has been confirmed with by Indian colleagues. And I like this study because they use only the sun exposure with filter to remove the visible light or to remove the UV. And you can see that both UV and visible light are able to trigger hyperpigmentation. So visible light is able to induce hyperpigmentation, but we need to know for better protection what kind of wavelengths are involved in this hyperpigmentation. So we demonstrated 6 years ago already that in fact it's only the high energy visible light, meaning the blue and violet light, that is able to induce, as you can see here with the IT8. So the lower it is, the stronger is the pigmentation. So you have a very nice dose response with the blue light and no effect of the red light. So it's only the blue light that is able to trigger hyperpigmentation. And you can see here this example after only one exposure to blue light, and it's a very long-lasting hyperpigmentation. And you can see here with the P53 staining, and I remind you that the activation of P53 is the main pathway activated by the UVB, but it's not the case for blue light, meaning that the blue light has other pathway to stimulate the pigmentation. And we were able to demonstrate it 2 years ago that in fact melanocytes are literally seeing the blue light thanks to a receptor called opsin-3 that we have the same in the eyes. And basically, I won't go into details, but when our skin is exposed to the blue light, our melanocytes sense the blue light thanks to opsin-3. This activates the pathway that will induce the production of melanocytic enzymes such as tyrosinase. But it also promotes the complex of tyrosinase. And when tyrosinase is complexed, it stabilizes its activity, explaining why we have such a prolonged melanogenesis after exposure to blue light. So the question that came after we demonstrated that the blue light is able to stimulate hyperpigmentation is, what about the blue light emitted by the screen of our devices, computer, TV, or cell phone? what we have to keep in mind is the intensity, the irradiance of the blue light. And in fact, of course, this is not the same intensity when we compare the sun with those screens, because the intensity of the most powerful TV screen is 100 times below the irradiance or the intensity emitted by the sun. And of course, you can imagine that if you receive, for example, 60 joules of blue light in 2 hours after sun exposure, it won't have the same effect as 60 joules delivered after 1 week or 1 month of exposure to the screen of our device. And to be sure that these blue light coming from devices are not affecting also melasma, which is a more sensitive disorder to blue light, we perform a study where we measure the blue light emitted by the most powerful laptop, TV, and phone. And as you can see here, it's, as I mentioned, 100 to 1,000 less intense as compared to the sun. So we take the most powerful screen and we combine this, we calculate the daily exposure of 8 hours a day for 1 week. And so we exposed the melasma patient, half of the face of melasma patient, and for 5 consecutive days. And we measure the MESI on each side of the face, and we also measure objective colorimetric comparison. And as you can see here, there is absolutely no change in the two sides of the face, meaning that the blue light emitted by the device screen does not worsen melasma lesion. So we can reassure our patient the blue light coming from the sun can trigger melasma relapses, but it won't be the case with the screen of their devices. So the next question is, can we protect against the visible light induced pigmentation? The answer is yes, but so far we have to use physical solution, physical barrier, such as iron oxide or pigment. And you can see here, for example, that the visible light induced hyperpigmentation, and here increasing concentration of iron oxide, and you can see that we can nicely prevent this visible light induced hyperpigmentation. And it has been demonstrated that when we combine the UVA and the visible light, they are both acting on pigmentation. So the clear conclusion is that when we choose sunscreen for pigmentary disorder, we have to be sure that they are protecting not only UVB, but also long wave UVA and high energy visible light, meaning the blue light. So to conclude about this blue light and hyperpigmentation, which kind of patient are concerned? All patients with skin type 3 and higher, and all patients, whatever their skin type, when they are presenting melasma, PIH, or actinic lentigo. So, does the protection against blue light can prevent the relapse of melasma? We answered to this with a monocentric randomized comparative study in 40 patients with melasma. All the patients were included in the study at the end of our winter in April, and we end the study at the end of the summer. The evaluation was done on MESI score, on standardized picture. There was no significant differences in the quantity of sunscreen used. And you can see here that when we use a very good UVA and UVB sunscreen, there are still some relapses after the summer. However, if we are using exactly the same UVA and UVB filters, but we add a protection against visible light, you can see that you can almost prevent completely the relapse of melasma. The same type of study has been performed with actinic lentigo, and again, same type of result. If you are protecting only against UV, you don't have any prevention. But if you protect against UV and also visible light, you can significantly decrease the pigmentation of actinic lentigo. What about PIH? We developed 2 years ago a model of an in vivo model of PIH, and to make a long story short, we've been able to demonstrate that only low doses of ambient light are sufficient to induce post-inflammatory hyperpigmentation. And we are unfortunately seeing that all the time with our patients. We explain to them to not expose them to the sun, but despite this, they have still post-inflammatory hyperpigmentation. So only the area completely protected from any radiation with an opaque dressing were able to not develop PIH. So the conclusion for the photoprotection part is that we know now that wavelengths of solar radiation well beyond UVB have an impact on skin, and especially UVA, long-wave UVA and blue light. So as a dermatologist, we have to advise our patient to not choose a sunscreen just on relying on its SPF index, especially when it comes to protect them for a pigmentary disorder. We know now that it's blue light that stimulates a potent and prolonged hyperpigmentation in skin type 3 and higher. And we know that it's directly through the melanocyte that will sense the blue light through their opsin-3 sensor. And finally, it's now demonstrated that blue light participated to the induction of PIH, actinic lentigo, and melasma relapses for all skin types. So the optimal photoprotection to prevent hyperpigmentation should clearly cover UVB, but also UVA and blue light. So how to manage post-inflammatory hyperpigmentation? Of course, we have to avoid any procedure during summer period. We have to be very careful if there is any personal history of PIH or in individuals with Asian ancestry, because we know that they are more prone to post-inflammatory hyperpigmentation. Before, if there is no risk factor, before the procedure, we have to put the melanocyte on rest. So we have to advise a strict photoprotection for at least 15 days before the procedure. After the procedure, we have to use at best an opaque dressing for at least 15 days. It's possible after surgery, but after, for example, a peeling on the face, it's not possible. And in this case, again, we have to advise a sunscreen covering UVB, UVA, and visible light. If there is a risk factor, of course, we have to put the melanocyte on rest with photoprotection, but we can also discuss 4% hydroquinone for the 15 days before the procedure. After the procedure, again, opaque dressing or sunscreen, and it's better to use potent topical steroids for at least 15 days, because we know now that the gold timing for post-inflammatory hyperpigmentation is about 15 days, maximum 3 weeks. When it comes to the treatment of PIH, it's of course more difficult. Again, the photoprotection covering all the wavelengths are mandatory, and I usually recommend to use Klingsman duo. So 4% hydroquinone and topical steroid. I avoid to use tretinoic acid in this case for at least 4 months. The tranexamic acid has been reported in the early stages of PIH, but only in some cases, and it needs to be confirmed before using it in clinical practice. In late stage of PIH, or if PIH resists to Klingsman trio, we can discuss a test session with Q-switch or picosecond laser. Sometimes we have good results, but we have to warn the patient that are high risk of failure or worsening. So we have to propose to make a test session before treating the entire lesion. What about treating lichen planus pigmentosus? It's very difficult to treat, as you know, and there is no treatment truly effective when the inflammation has resolved. And I liked very well this study performed by Indian colleagues. It's an open-label prospective study in 32 patients, and they propose oral isotretinoin 20 milligrams per day for 6 months associated with a sunscreen. Only 27 patients completed the study, and 3/4 of the patient have good to moderate improvement, which is quite good for such a difficult to treat disorder. And there is also an action on the pruritus. And I've been very interesting to see a very recent case report of a 36-year-old woman with a very severe lichen planus pigmentosus evolving for 5 years. She failed to respond to many treatments. So the colleagues start isotretinoin 20 milligrams a day, and they notice an improvement after 2 months, and there was a marked improvement after 9 months. And you can see here the face of this lady after 1 year. It's a very nice improvement while she failed to respond to all other treatments. So it's really interesting. So Of course, when the lesions are still inflammatory, we have to, such in this case, for example, here we have to prescribe oral steroids 1 milligram per kilogram per day. But when it's these post-inflammatory stages, like we have in these two ladies, we can propose, it's off-label, but I think it's very interesting. And in my practice, I have also some nice results, isotretinoin, 20 milligrams a day for 6 to 12 months. Finally, how to deal with melasma. So I wanted to emphasize that melasma is much more complex than we thought initially. We have now proof that the dermis component, especially fibroblasts, there is fibroblast secreted factor such as WEAF or SFRFP2. I won't go into details, but those fibroblast secreted factor plays a key role in melasma pathogenesis. But not only the fibroblasts, we know for years now that in melasma lesions, we have an increased vascularization. And that, for example, this study, the author performed some biopsies in lesional skin as compared to perilesional skin. And you can see the very strong increase of vascularization. And you just have to look at melasma with dermoscopy to see it. And we confirm this Asian study in European group. And we observe that indeed in lesional area as compared to non-lesional area, we have an increase of elastosis and increase of vascularization. Asking the question of the role of vascularization in pigmentation. So already in 2009, I was asking the question of the role of the vascularization in pigmentation, because if you are looking at the melanocytes, they are closely related to the capillaries of the dermis. And on the surface of melanocyte, we have many receptors for factors secreted by endothelial cells. And in fact, 5 years ago, we made a study and we assessed 100 benign lesions with high magnification digital dermoscopy. And as you can see here, these are cherry spots. And you can see that below the pigmentation, we have an increased pigmentation. And again, to make a long story short, we were able to demonstrate that the endothelial cells of the dermis secreted endothelin-1, and this endothelin-1 will activate the pigmentation in melanocyte through the endothelin B receptor. And you can see here in this reconstructed epidermis, there is no UV, just in these two conditions. In this one, there is endothelial cells just below, and you can see how they can they manage to stimulate the pigmentation. And if we block the endothelin B receptor, you can see that we can nicely prevent this vascular-induced pigmentation. So I don't have time to go into details, but for those who are interested in melasma, we have many new data. And we, with my friend Mauro Picardo, we made a review that is available in this journal. But we can say now, and we know that melasma are triggered by UVB, but also UVA, visible light. And it's not only the keratinocyte and melanocyte, but we have an interbasal membrane. We have also stimulation with many factors secreted by fibroblasts, and also a stimulation by endothelial cells, and maybe also a stimulation by sebocytes. So we clearly need to have a global therapeutic approach and not only targeting the pigmentation on melanocytes. And some new treatments are targeting these other factors such as vascularization, and one of them is tranexamic acid. And I like very much this double-blind placebo-controlled study. They use tranexamic acid 250 milligrams twice a day with a sunscreen compared to placebo and sunscreen. And you can see that there was a nice and significantly improvement of the melasma after only in the group with tranexamic acid. Unfortunately, as you can see here, when we stop the treatment, most of the patients will relapse. There was no side effect. One subject dropped out for myalgia in the tranexamic acid group, but we have to keep in mind that it's off-label use and we don't have to use it if there is any risk of thrombosis. What about microinjection of tranexamic acid? Here, the data are less important, clearly. There was tranexamic acid mesotherapy versus normal saline serum for melasma, and the tranexamic acid showed to be more effective, but it's a non-randomized, non-blinded split phase study. when intradermal injection of tranexamic acid were combined to meconium-linked tranexamic acid, there was no statistical differences. And this is probably one of the best studies so far with in microinjection of tranexamic acid, is the use of fractional thulium laser plus or minus topical applied tranexamic acid. And in this double-blind split phase study, randomized study with 6 months follow-up, there was no statistical difference between the two sites. So probably it's explaining by the fact that the hole made by the thulium laser is not enough, and we clearly need to reach the dermis. So there is critical importance of the penetration of topical tranexamic acid to reach the dermis component. Now, what about the topical use of tranexamic acid? Many uncontrolled studies, many cases reported. And if we are looking at prospective randomized trial, we have two that compare 5% tranexamic acid with 3 or 2% of hydroquinone. There was no statistical difference in efficacy between hydroquinone and topical tranexamic acid, but with a better tolerance for topical tranexamic acid. And only one prospective randomized comparing 5% tranexamic acid versus placebo, and unfortunately there was no statistical difference. So far it's very difficult to advise to use topical tranexamic acid. There is a clear need for additional well-designed control study, and clearly if we are using topical tranexamic acid, it requires good penetration of the compound, especially to reach the dermis and where are located the vessels. So clearly oral tranexamic acid is working, the rest is still under debate. So to conclude, here is what we are proposing for melasma. For all patients, photoprotection, and again, we clearly need to protect not only against UVB, but also against long-wave UVA and visible light. And discontinue the hormonal treatment in women who are taking that only if the treatment has been introduced in the year before the onset of melasma. In all other cases, there is no interest of stopping the hormonal treatment. Of course, all the patients have to be advised to avoid any friction. And I'm always starting with the gold standard so far, which is the Finland trio for 3 to 4 months. We have here our combination. I'm starting that at the beginning of the winter, and I'm giving that for 3 to 4 months. If it's effective, we have to keep in mind that melasma lasts for 10 to 20 years, so we need a maintenance treatment. So again, photoprotection, and we have to use cosmetic blanching cream. And to this respect, not all the cosmetic blanching cream are not the same. So you have to ask what about the efficiency, if there is any clinical study that have been performed to demonstrate the efficacy of those cosmetic blanching cream. If it fails, we can discuss a peeling, but there is a high risk of PIH, especially in dark skin individuals. I don't have time to discuss about the pigmentary laser, but it's not recommended. You have high risk of relapses and worsening. The lasers such as IPL or pulse dye laser targeting the vascular component are effective. It's well demonstrated now, but we cannot use that in dark skin individuals because after the skin type 4, you have a high risk of PIH. Oral tranexamic acid is clearly interesting, but it's off-label use, and we have to use it only 3 months a year. And in development, we have topical endothelin B receptor inhibitor, DKK1 agonist, and chemical approaches to prevent visible light-induced hyperpigmentation. So you can see that there's a lot of progress in melasma and more that are coming. And I would like to thank you for your attention.